Natalia. Thank you, Scott. We'll be covering the planning aspect of the lecture today, and I do want to state that the planning that I'll be talking about will be from the perspective of how we've been doing at Stanford here. The disclosures, I don't have anything to disclose. So I just wanted to point that out. And as an overview of the talk today, I'll go through kind of briefly on the simulation process, what the important aspects of simulating a GBM treatment. I'll describe the VMAT technique. We primarily use a rapid arc or a VMAT technique for treatment delivery. And then I'll talk about the planning goals and how that is kind of important for dosimetry to kind of know what is possible when determining the plans. And I'll go through a bit about the contouring and optimization process as well. And then I'll also touch upon plan evaluation and how the kind of dosimetry tend to know when they're finished with the plan and when to hand it off for review. In terms of simulation, we use a 3-point mask that's standard for all the brain CNS treatment here. It's a short mask. It kind of stops around kind of the neck, and it's a thermoplastic mask. I think most people are familiar with this immobilization device. And the one that we use is the Clarity S-type mask. And you can kind of see that it's this one for this patient has been done, set up really nicely. It's kind of anchored around the chin, the nose, the head, and this is really important to help stabilize the head position for IMRT treatment. A lot of the times there are a lot of critical structures nearby, so we want to make sure that the patient is firm and tight inside the mask. We also, I think in the last year and a bit, we've also changed the way that we've localized these patients for SIM, and you can kind of see in this example here that this patient's higher up on the couch. This is the CT couch here. It's kind of same as the treatment couch, but having the patient immobilized or kind of indexed further up, higher up on the bed, that ensures that when it comes to planning, if we need to use non-coplanar angles, that there's going to be sufficient clearance. We've had problems in the past where we've had the patient kind of index lower down on the couch, and that's caused problems if we were trying to use non-coplanar angles. And I'll talk a bit more about when we use non-coplanar, coplanar angles. For the CT itself, we tend to use a very fine slice thickness from anywhere between 1 to 1.5 CT slice thickness. This is important to ensure that we capture or kind of have on the CT kind of sufficient kind of information to kind of show up the kind of neuroanatomy such as the chiasm, cochlears, and as well as the optic nerves. And one thing that I do want to point out is that we plan with planning risk volume margins. So we have margins around our organs at risk, and we plan to ensure that our dose constraints are met to these margins around the organs at risk. And the margins take into account a number of factors, including kind of contouring uncertainty, kind of image registration uncertainty, but as well as kind of intrafraction motion. If we want to make sure that the mask that we build is firm and rigid for the patient, so that there's not much movement during the treatment delivery itself. And there are publications around how effective mask or kind of these immobilization devices have been done quite a lot. This is an older publication in the Red Journal, and it just shows that with the different type of masks that are available at the market at the time, these 4 images kind of show the different masks. This is like a mask that goes around down to the shoulders, around to the neck. But overall, this study, they did cone beam CTs before treatment, and then they also did cone beam CTs after treatment, and they evaluated kind of any motion in there, and they found that the overall displacement was within a millimeter. So, these masks can keep the patient kind of immobilized quite well within a millimeter. So now there are other masks available. 2013, there's a lot of vendors out there, and one that we have used, and not necessarily for fractionated CNS treatment, more for SRS, but you can use this for fractionated IMRT treatment as well. But this is the open face Q-fix mask. The difference between this design and the previous mask that I showed you is mainly it's got this open face to it, and this open face area allows the department to use a surface guided patient monitoring device during treatment. And there are Align RT is a common, well-known, established surface guided form of patient monitoring system. There's a few infrared cameras that are set up inside the room, and it can kind of reproduce the patient's position, kind of model it and ensure that it will track the patient. And with an open face mask, it's able to visualize the patient a bit better for monitoring compared to an open face, a closed face mask. And with the SRS mask as well, there's kind of thicker areas around the chin, around the forehead, and this kind of just helps reinforce the patient's position. The perforations inside, kind of on the mask, is also been designed so that it doesn't stretch out and compromise the integrity of the mask as well. So.
Daniel, we lost the sound.
Can you hear me now?
Yeah, we can hear you now.
Okay. Planning. I think it's important to, when we begin any case, to understand the planning goals and to kind of understand what's a high priority and what's not necessarily kind of constraints that can be relaxed. And when, we've worked with Dr. Soltis for a while now, and he's established quite a very neat summary or guidelines of, what he expects to, what's possible in the plans, these IMRT plans. And in general, we try to, at Stanford here, we try to cover all of our targets, PTV, to ensure that 95% of the volume receives the prescribed dose, so 60 gray, as we were talking about the dose prescription. PTV Dmax, so we try to keep the plan quite homogeneous. So the Dmax in the plan is generally around about 107%, 108%. We also try to prioritize the minimum dose to the GTV, or kind of the high risk area. And as well, what's also important that we try to establish is to ensure a minimum dose to where the PTV overlaps with organs at risk, kind of critical organs at risk, such as brainstem and cochlea, and not cochlea, optic nerves, optic chiasm. We try to ensure a minimum dose for that region. And these are the constraints that we have as a kind of a template, and these are kind of adjusted or modified, kind of depending on the patient or the clinical case. But in general, the optic nerves and optic chiasm have a max dose constraint of 50 gray. The PRV, which is a 3 millimeter margin around the true organ, this contour has a constraint around a bit higher, around 55 gray. Brainstem max is 55 gray. The PRV around the brainstem is at 60 gray. And there's also a volumetric constraint to the PRV. And then we have kind of softer constraints to the eyes, the lens, cochlea, as kind of Dr. Soltis had mentioned before. Depending on the case, this may be a high priority case, but it has a max of 40 gray. And then the skin as well, we try to keep this low. We also have a priority on the skin, so body -4. The VMAT technique be based on either partial arcs or full arcs. It really depends on the tumor, the PTV, and its the size in the brain, and whether or not it crosses the midline kind of to the other hemisphere of the brain. But generally, with ipsilateral targets, you can get away with a partial arc. And then for targets that are larger, that crosses kind of both sides of the lobes, then a full arc can be used. And non-clear planar angles can be used. We don't routinely use non-clear planar angles on all of our cases, but in some scenarios we do use non-clear planar angles. There are limitations with the imaging, and there could potentially be clearance issues, and as well, for kind of in terms of efficiency on treatment, having to go in and rotate the couch for treatment is probably not ideal in a lot of for all of our cases. And for planning, we use a pretty small calculation grid, 2 millimeters, and we've been using Accuros to model the dose in all of our cases. Now, this is just an example of the use of non-clear planar angles. So non-clear planar angle, we would use a sagittal arc, which has the couch kind of flipped 90 degrees from the gantry itself, and it generally starts anterior to the patient and then falls to the back. And this can be useful for certain cases whereby we need to limit the low dose wash to a critical structure such as the hippocampus on the other side, that's kind of contralateral to the target. So in some cases, non-clear planar angles are quite useful. Generally, when you want like a low dose sparing to an organ on the other side, further away from the target. With non-clear planar angles, though, we do ensure that there is monthly checks to make sure that with the couch rotating away from along a different plane, then there is no isocenter drift with the couch clearance. And here at Stanford, we do have a pretty tight monthly QA that ensures that the isocenter drift or kind of walkout doesn't go beyond a millimeter or so. So it's pretty tight. So the isocenter comes up really well with non-clear planar angles. One thing that I found quite useful, important in terms of kind of putting together a VMAT technique is to evaluate the collimator rotation. And this can help with conformality, panhomogeneity, and as well organ sparing. And here's an example of a case where there's two arcs, partial arcs that are used, and always found that collimator angles that kind of 90 degrees from each other helps with achieving high quality plan, high conformality, lower kind of a more homogeneous dose distribution. I mean, with different collimator angles, you are kind of effectively allowing the system more freedom or kind of control points to shape the dose during the optimization. Whereas if you have collimator angles that are kind of similar in direction, the MLCs can only move in any particular plane, so it kind of limits how conformal the dose distribution can be. And this is an example of, so this is kind of two plans, one with collimator angles perpendicular to each other, and then one plan two has collimator angles pretty close to their own kind of similar in plane. And you can see that the Dmaxes to targets can be kind of quite similar, optic nerve, optic chiasm, brainstem, the Dmaxes are similar, but then there is a difference in homogeneity in terms of being able to kind of get the dose into the target. I found that just helps with having different collimator angles. Another approach to kind of help kind of shape the dose is to split the field up. And in this case, you can see these are three different arcs, and splitting the field is effectively having the field kind of open up to only half of the PTV, so having a lower half and a top half, and then having another field that kind of opens up to the entire area. The advantage of having a split field technique like this is that it allows the optimizer to have these leaves here that can prioritize with shielding out kind of critical organs at risk, such as like the chiasm or the optic nerve. And when you have a larger field opening, the MLCs will kind of compete against kind of opening up, covering the target, or trying to shield out the target. So by kind of having this shortened field like this kind of helps you with kind of shaping the dose quite well. And this is a technique that we use for hippocampal, whole brain hippocampal sparing, and it can be applied to other sites as well. And kind of just an example of a plan with the full field kind of opening versus a plan with kind of one of the fields split up into two, like an upper and a lower field. Once again, you can achieve kind of very similar Dmax constraints to brainstem, chiasm, but then have a nice kind of homogeneous looking plan. And I'll show you kind of what I mean about how the MLCs interact with the split field technique. So on the bottom left hand here, you can see the MLCs, when it runs around, it can kind of shield out this is the chiasm here. So you can focus on shielding out the chiasm while still having the upper half kind of covering the target. Whereas when you have a full field, then the MLCs will kind of be traveling across the field, and I think it will kind of struggle with trying to cover the target while shielding out the kind of a critical organ. It's a tool that can be used kind of depending on the clinical case. Now, there are a couple of planning rules of thumb that I've found to be very useful, and this can be applied to any other clinical site, not just brain, central nervous system targets. But, it's important to differentiate between hard constraints versus soft constraints. So hard constraints are kind of constraints that must be met for organs, and if you need to sacrifice PTV coverage, then so be it. Whereas soft constraints are kind of negotiable. This will definitely determine optimization priorities. And from there, I think if you calculate, kind of knowing what the hard constraints are and soft constraints are, you can calculate what the expected kind of coverage to the PTV will be, or the kind of the normalization value. So you can figure out how much of the PTV should be receiving the full dose. And you should also be aware of kind of the limitations of your system and what is possible in terms of achieving kind of different dose gradients. And one rule of thumb that I've always adhered to is that with kind of any fractionated treatment, the IMRT dose gradients can drop like 2 to 3 gray per millimeter. I mean, with SRS, this dose fall off can be steeper, but with kind of general IMRT fractionated treatment, you can plan for 2 to 3 gray per millimeter. So in this example, we've got this big PTV that's overlapping with the chiasm, the optic nerve, and the brainstem PRV. The PTV, 60 gray volume, it's quite large. It's almost 260 cc. The brainstem, these are the constraints that have been applied to this particular case. Brainstem PRV with a Dmax of 58 gray, so it's a lower Dmax than the PTV, the prescription dose. So there'll obviously have to be sacrifice of the PTV at some point. The chiasm as well and optics have a Dmax of 54 gray. And then for this case, there was also a cochlear PRV max of 35 gray. So understanding what needs to be met will give you, will shape how you determine your optimization structures and what to input into the optimizer. So in this case, the best way to evaluate it is to look at your prescription dose, look at your constraints, and then look at the difference in dose that needs to be achieved. So for the brainstem constraints, 58 gray. So you're dropping to the dose difference of 2 gray. So you should be able to drop that with a 1 millimeter margin. So the PTV, so this part of the PTV should get 60 gray, and it should drop to 58 gray within a millimeter. And then same with the optics. If there's a dose difference of 6 gray, then you should be able to put in a margin of 3 millimeters to facilitate the dose fall off. And with a cochlear with a lower max dose constraint, you need a steeper dose gradient. So you need a larger margin to get to 60 gray to 35 gray. So once you crop out your PTV, original PTV, from all the OARs with these margins, you'll get this residual volume left over. And if you find the ratio, you'll find you can figure out how much you can expect to cover the original target by. So in this case, if I wanted to meet all these constraints, then I would know that 94% is the expected coverage to original PTV. So this is the, not necessarily the PTV eval, but the PTV that will be used for planning the optimization. And so just going through briefly describing the IMRT optimizer. So we have the Eclipse version 15.6, and this is a photon optimizer. And if you're not familiar with this optimizer, it runs through multiple levels as it kind of adds more control points. It runs through 4 different levels, and they're called MR1 through to MR4. And these levels, as the optimizer progresses, it'll add more control points. And it'll kind of affect how you can kind of interact with your dose constraints. So generally with TNS planning or with any other clinical sites, the first level of planning, the MR1, I tend to look at the conformality of the prescription dose, ensure that the PTV, once you put your optimization objectives into the PTV that's been cropped away from your OARs, you want to ensure that the plan begins by putting the dose needed into this target. You don't have to get a perfect plan at this initial stage of the optimization, but you should be able to kind of set the the blueprint for how the plans kind of finalize, kind of turn out in the end. And for any hard constraints such as optics or brainstem, you can also feed it into this first initial level so that the control points are kind of in place to kind of facilitate the dose gradients that you need. And then once the software goes into the next MR level, it kind of adds more control points, so it's kind of getting a bit more fixed in how the plan's going to look. You can put in the objects to kind of shape the overall dose, and you just want to keep an eye out to make sure that your plan priorities are still prioritizing the target, which in this case is a TSPTV, and it's slowly kind of putting in a cost to lower the dose to other areas like the skin and the cochlea, etc. And then MR3 and MR4 are kind of like the final phases of the optimizer, and you can skip these through, but what I found is important is with Eclipse's optimization tool, it allows you to calculate an intermediate dose, which effectively uses the full volume dose to calculate the dose in the plan, and then it'll bring it back into the optimizer, and it'll feed that information to kind of show you what the plan is looking like, so that you can continue tweaking the dose. I mean, the optimizer is a fast kind of dose calculation software. It doesn't kind of accurately model the total kind of dose that's running through the plan, but by inputting the intermediate dose into the optimizer, this should give you a better picture of how your plan is going to turn out. And then in the final stage of once the plan has done its intermediate dose calculation and it's fed back into the optimizer, you can use the final MR level to fine tune your plan. Look at the hotspot and look at the overall homogeneity and the conformality, and more importantly, is to look at the actual dose to the PTV. So before I mentioned that, with a plan, if you know what the expected coverage is going to be, then you can ensure that, if your plan is heading in the right direction, then the actual dose that's displayed in the optimizer is close to the prescription for 94% coverage to the PTV60. So this ensures that you won't, once you do your final dose calculation, that you're not going to see a large change in those two OARs and target coverage. In terms of plan evaluation, it's what I tend to look at is the prescription dose conformality. Running through the plan, you want to make sure that the plan looks, the prescribed dose, in this case 60 gray, it's nice and conformal around the OARs and around the PTV. And as well that obviously the constraints are all met. And as well the Dmax and the 1 at 5% is not spilling outside of the PTV. And if you have your plan kind of normalized and optimized in the right way, then you shouldn't see 1 at 5 spilling out there. And as well, the minimum dose. So the minimum dose to where the PTV overlaps optics and brainstem should be, there should be dose through there. It shouldn't be running cold. And with IMRT, you can get like a kind of 5%. You kind of figure out that with the constraint that's limited by the organ at risk, the minimum dose should around be about 5% below that constraint. So for the optics, you can get away with around about 48 to 50 gray for a 52 gray max on there. So I guess in summary, with planning for this, and then I guess for any other clinical sites, I think it's important to differentiate between hard constraints and soft constraints so that you know what to expect when optimizing the plan. And kind of you should be able to know what your plan is going to look like and how much coverage should be in the plan before you begin the planning. And to get to this plan, then it's important to optimize or kind of collimate angles and the number of arcs to ensure that you're properly shielding organs at risk and covering the PTV. And I don't want to take up too much of your time, but I just wanted to thank everyone, Natalia, Dr. Soltis, medical physics team, the RPTs, and the dosimetry team for all the work that we've done.
Thank you so much. Excellent lectures. Thank you. Many thanks to our speakers for teaching us today, and I will open the floor for questions. Are there any questions? You can unmute yourself to ask a question.
Hello, I am Dr. Zoya Shepel from Kyiv. I take one maybe practical questions. What's the maximum displacement of the central structures you take to the post-operative radiation therapy in your clinic?
You mean what's the maximum displacement?
Yes, maximum displacement central structures. Because in our clinic, we take patient on the treatment when displacement less of 6 millimeters for central structures.
Oh, like midline shift? Like,
Yeah,
Yes,
midline
midline.
shift.
Yes, midline.
oh, I see. I mean, well, if they have that much shift, they may be more likely to be symptomatic, so they would be more likely to need steroids during treatment. But we still treat them. I would not would not delay treatment or wait for it to get smaller. Here, if it looks like, excuse me, if it looks like they're going to require steroids for weeks or months for the concern that radiation may cause more swelling, then we are aggressive in using bevacizumab as a steroid sparing agent. There's no role for bevacizumab routinely in patients with GBM otherwise, but to spare steroids, we do use it.
Mm-hmm. Thank you very much. We also use steroid on this situation, but sometimes it's state of patient don't normalize, and we need we need send the patients for the neurosurgery for stabilize the situation at the time prolongate for start for treatment. It's think bad situation for the patients.
Yeah, we yeah, we do the same thing here. We get concerned if they have a steroid requirement and then may rescan them, and sometimes in the middle of radiation they'll go for a repeat surgery.
Thank you very much. Very interesting and practical lectures. Thank you.
Thank you.
Excellent. Any other questions?
Hello, can you hear me?
Yeah.
Yes, thank you so much for presentation. I have a question to Dr. Scott Soltis. It was very interesting to hear about TTF. However, I wanted to ask whether it's useful to use hypothermia for treating gliobastoma, because now in Switzerland they started to implement it quite rapidly for different types of tumors, also including glioblastoma. But there was not many clinical trials regarding this approach. I'm just curious to listen to your thoughts about this.
For hyperthermia, yeah. Wow. Yeah, I guess the problem is just getting the heat there. There are studies of where they place a catheter into the resection cavity and they do like a convection enhanced chemotherapy. So there are attempts to try to intensify local treatment that way, but yeah, I'm unaware of any hyperthermia studies.
Okay, thank you so much.
Probably just technically it's difficult to do.
Yeah, thank you.
Scott, I have a question about TTF. What are the side effects?
The main one is skin. So it's skin toxicity. You need to shave every 3 or 4 days, replace the rays every 3 or 4 days. So the peeling on and off is can affect the skin. It's hotter. It's hot, so at summertime it's a little bit harder. Most of the patients end up seeing oncology, dermatology here for management.
So out of your patient, how many % would choose to do TTF? Approximately?
Yeah, here I'd say it's kind of a lifestyle decision if they want to do that. I mean, certainly it's probably a third, I think.
Okay.
Kind of regional differences. Other parts of the country, I hear it's over half. So I think nationwide it's around 30%.
It's pretty good still. Any other questions?
Yeah, I have a question to Daniel. Thank you both for great presentation. My question about parameters maximum dose for PTV or ORs. You mean it's a point dose or dose to some volume like 2% like in ICU 83, or maybe to some volume like 0.03 cc or point?
We've been using some of the Eclipse kind of point dose max, which is very, very small. It's like smaller than a voxel. So we use that as our kind of constraint, kind of plan evaluation, and in a way that's a more conservative approach to what we're actually getting to the target. It's the Dmax to kind of like 0.03 to optic kind, like brainstem is probably a lot lower than what we're actually getting on the plan. So
yeah, something.
Yeah, but clinical trials typically require 0.03 cc instead of Dmax. It depends on your voxel size.
Yeah, different software will kind of portray it differently.
Report it differently. Any other questions?
Yes, can I ask questions, please? Thank you for the great presentation, but I have a question. What we need to do if the situation when the tumor is localized on the brainstem area, is the standard situation 60 grays in 30 fractions? It is correct or not, because the tolerance dose of the brain first term is 54 grays. So what we need to do the situation when the tumor is located with the brain area?
Yeah, good question. Well, a few things. If it's truly brainstem glioma or thalamic glioma or spinal cord glioma, it may not be GM, it may be H3K27 altered tumor. Those are like the diffuse DIPGs in children. So the name of them may be different, but wherever it is, I respect I don't push normal tissue constraints. So my brainstem may get, say, 56 gray, but I don't give it a full 60 gray because it's not still not entirely clear if dose escalation matters in the modern era. Yeah. So I don't.
Thank you. I do the same. Thank you. Thank you very much.
What you're
Yeah.
And I guess I'll just ask the last question, if I may. What's the hope for GBM patients? So we've seen years and years of trying to improve the outcomes, but in your opinion, Scott, what can help us to do better for our patients?
Yeah, well, just continue research and clinical trials. There's always things that are promising, and you got to continue to explore them. Similar to other histologies too, more a personalized approach with better molecular characterization of all these may lead to different treatments. Right now, they're all lumped and they all get Temodar, but we're looking at subgroups of GBM patients to see what's best.
Okay. Excellent. Thank you so much. That was excellent first lecture. So our next lecture will be on Friday. Please join us. And we will be translating this lecture and posting it on the website, and I will send you the recording as well. Thank you. Till Friday.